On behalf of the Duke Margolis Center for Health Policy and the Alexandria Summit, I'm Mark McClellan. I'd like to welcome all of you to today's webinar on building COVID-19 diagnostic capacity now and for the future. This is a challenging time for everyone around the world. We're focusing today on one critical aspect of the response to COVID-19, the availability of rapid, reliable diagnostic testing to help manage the wave of the pandemic that we're facing now, as well as to contain future outbreaks. This is an essential element of moving beyond the extreme but necessary physical distancing and lockdown measures that are in place today. We're going to kick off this webinar with an opening discussion on the path forward in the pandemic. That'll be led by former FDA Commissioner and current resident fellow at the American Enterprise Institute, Scott Gottlieb. Then I'll have a fireside chat with Tim Stenzel, who directs the Office of In Vitro Diagnostics and Radiologic Health at the U.S. Food and Drug Administration, an office that's been centrally involved in the innovation and access to diagnostic testing. After that, we're going to have two 45-minute sessions. The first on strengthening the diagnostic supply chain and improving access, and then the second on strategies for maximizing our testing capacity, enhancing our surveillance capabilities through innovation in diagnostics and innovation in how the health system and public health authorities work together to detect and tamp down future outbreaks. We're going to end with some closing remarks from our co-sponsors in this event, the Alexandria Summit. Just a couple of logistics before we get started. This webcast is being recorded and it will be available on the Duke Margolis website after the event. We have a lot of participants. We are glad you're all with us today on this timely set of issues. If you'd like to submit a question or comment for us to build into this discussion, please tweet it to #COVID Diagnostics. That's #COVID Diagnostics. And for more on our COVID-19 activities, you can always go to our website at healthpolicy.duke.edu. We're also going to be tweeting about additional sources of information on diagnostics and the pandemic during the course of the webinar. So to start us off, I'm really pleased to introduce my longtime colleague, Scott Gottlieb, former FDA Commissioner and fellow at AEI. Scott, thanks very much for joining us here today. I know you've been busy.
Thanks a lot. Thanks for having me, Mark.
Well, you had a Wall Street Journal op-ed on this topic with Lauren Silvas, who will be joining us later. In that, you talk about how rapid diagnostics, targeted surveillance, and boosting the supply of needed materials for these tests is a critical part of combating COVID-19. So could you talk a little bit about how diagnostics and ramping up these capabilities fits into the overall response, maybe focusing first on the short term, and then we'll get to the longer term?
Yeah, well, obviously on the short term, Mark, and I appreciate the opportunity to be here today. On the short term, building out the capability is just a function of being able to diagnose people. Right now, if you look at what's going on, they're not able to do a lot of diagnostic testing in the community. The hospitals, most of the diagnostic testing is going on around the hospitals right now. And in fact, the administration came out with recommendations last week, and the states followed, that you shouldn't be doing community testing. That was a function of the fact that there was a backlog of tests at the hospitals, and you heard reports, anecdotal reports of people waiting days to get their tests back. And what was happening was they weren't able to increase flow at the hospitals. People were being admitted to the hospitals and were sitting in the hospitals awaiting test results. And so they wanted to focus all the diagnostic screening capacity at the hospitals. Talking anecdotally to some of the hospitals in New York, I've talked today to some of them, they have positivity rates of 50% or 70% right now. And that's a function of the fact that people who are getting tested are people who are presenting to the hospitals and are very sick. And as flu incidence goes down, people who are showing up with flu-like symptoms are more likely to have coronavirus right now. So that should come down. But it's going to be important to continue to expand capacity and expand testing into the community, because we need to get more people diagnosed. I think it's not just important to have a diagnosis when people are in the hospital to know whether or not they should be admitted and then manage them appropriately in the hospital. But I think giving people in the community, even who might have mild disease, a positive diagnosis changes behavior. I think telling people that they actually have coronavirus is going to make them more likely to self-isolate and make people around them more likely to take precautions. And if they think they have coronavirus, but they don't actually have a positive diagnosis. So there's a lot of virtue in, I think, trying to expand testing and give people a diagnosis. Now, as the epidemic runs its course, being able to do widespread testing in the community, as you well know, obviously becomes very important, because you want to transition away from these population-based mitigation tactics where we're sort of treating entire populations with public health tools, and treat individuals and move towards more case-based interventions. And in order to do that and actually target people who are sick, you've got to have widespread screening. And the report that we put out, that you were a co-author on, we talked about having the capacity to do 750,000 tests a week. We modeled that off of the average number of tests conducted during flu season. But during really busy weeks in the flu season, it's well in excess of that. They're doing 1 million or more tests. I think we'll be well in excess of that going into, we'll probably be at 700,000 by the end of this week, with the Abbott system coming on board and Cepheid's Gene Expert and what's already available in the academic and the clinical labs. But I think going into the week after that, we're going to approach 1 million, and it's going to ramp from there. And you'll see more systems come onto the market, more point of care tests getting cleared. And so, just to sort of close briefly, I see you shaking your head. Why don't we move on?
That's a great overview.
What we talk about in the op-ed that Lauren Silverson and I did was, so what do we need for the fall? I mean, what we need now and what we need for the fall, in some respects, there's some overlapping. The two circles overlap, and there's some common color in between. But in the fall, I believe you want a massive sentinel surveillance system where you're doing sampling of the population through a representative sample to try to capture where the virus may be spreading. So you're not just capturing people who are symptomatic, but maybe people who are asymptomatic and mildly symptomatic. And you can do that by layering it onto ordinary samples that are getting collected. You can do it based on a sample population that you may send self-swabs to and ask people to send it back in. But you want to do that at a massive scale, because we want to know where the virus is spreading. You want point-of-care diagnostics and very liberal use of those diagnostics. So you want CDC guidelines that recommend very liberal testing. You want this to be a reportable pathogen. You should pay doctors to report on it. You want those systems in every doctor's office. And so getting tested for coronavirus should be as common as a 5-year-old getting swabbed for strep throat. And then you want to do serological testing at scale. And you can again layer that on to normal blood draws and other kinds of routine collections, so you can understand what the background rate of seroconversion is. And so if 20% of New Yorkers have been exposed, but only 5% of people in Dallas have, if you have an outbreak in Dallas, you might behave differently than if you have an outbreak in New York. You want to be able to titrate your public health tools based on what your background serology is. And there's been some preliminary studies of people in healthcare settings, hasn't been published yet, but that shows pretty high exposure, upwards of like 10%. People who've seroconverted. And so I think you're going to find that in exposed populations, by the end of this epidemic, I don't think we'll have enough for herd immunity, certainly, but in certain hard-hit cities, you might have more seroconversion than you'd suspect, especially in people who are in frontline settings like healthcare workers. And that could obviously inform workforce issues and maybe who you put in frontline positions. You might selectively put people who seroconvert in those frontline positions. So those are the three tools. I think I'll just close by saying, and I said this on CNBC this morning, this isn't going to be like an inflection point where this kind of goes away. This is going to be with us until we get to a vaccine that can vanquish this. We're going to have to deal with this, and we're going to have to adapt our lives in a very meaningful way. I don't think the general population, the political class, and the markets have fully perceived that this is going to be in the background. Now, I think we can dramatically mitigate that if we can get an effective drug that can be used as both a prophylaxis and a treatment to help rescue patients. But a key to that is also going to be very, very robust screening on an order that we've never contemplated before in this country. And we need to start building that system now if we want it in place. We have the tools to do it. It's just going to be a matter of the funding and the public health capacity build out. And the will. I mean, it's going to inconvenience providers. I'm going to have to change practices, but we're going to need to do that if we want to make this a livable threat.
Yeah, and that is a really clear vision for where we can get to make this a livable and hopefully manageable threat in a matter of months. It is going to take some new steps on the part of healthcare providers. My sense is that they're willing to step up to be part of this national public health surveillance system. But before we get there, just a couple of quick things to close out on. In the short term, you mentioned the test supply really ramping up. But as you pointed out, it's not just the tests themselves, the materials that you need along with the test, the swabs, the pipettes, the capsules and so forth that are needed as well. What's your sense of where we are on dealing with those aspects of actually being able to do tests in the field where they're needed throughout the country?
Yeah, I mean, it's the truth that what's going to limit our capacity, at least to do PCR-based testing, where you're pulling from a global supply of reagents and plastic cartridges and pipettes and swabs, is going to be actually the low margin products, not the scanners. You're not going to have a shortage of Thermo Fisher scanners, but you'll have a shortage of pipette tips. And it's a lesson that, and you and I learned this at FDA, it's always the lowest margin component in the supply chain that ends up being in short supply precisely because it's a low margin component. It's underinvested, it's consolidated manufacturing, it's manufacturers that haven't invested in their own capacity, so it's hard to build out. So it's always the cheapest component that ends up being the weak link in a supply chain. I think that supply chain will continue to expand. Right now, there's a global pull on the supply chain, so that's really what's limiting it, and that's what's putting a limit on the upward capacity to do more PCR probably, and getting above like 1 million PCR tests a month. I think that's the virtue of bringing on systems like Abbott systems or Cepheid systems. Those manufacturers control their entire supply chain end to end. They manufacture their own components typically, and so they're going to be able to ramp their supply more reliably than others will that are dependent upon a global supply chain. And we're also going to figure out how to make some of these components interchangeable. I mean, swabs are the most obvious, where you can validate a self-swab or other kinds of Q-tips for swabbing people's noses rather than the synthetic swabs that are in common use right now. So I think that this is going to continue to improve and expand. You could think legislatively, as you're crafting a bill to build out this sort of massive screening system, I think there's two things you can do. One is you can start stockpiling this stuff. We never thought to put reagents in a strategic stockpile, but now we should think about that, and swabs and things like that. I mean, turns out we didn't think to put a lot of things in a strategic stockpile that we should have had there. But you can also potentially build in some preference for American-based manufacturing for these components. I think that there's going to be a different thinking around this now, and it's not going to look so nationalistic to build in preferences for domestically sourced components, for critical components to some of these healthcare products. I think, a year ago we would have looked askance at that, but I think now we might take a more a more industrial approach to how we do these things, because having domestically sourced manufacturing, we always were willing to accept that we wanted to have domestically sourced manufacturing for vaccines, and we got over that because we recognized how important it was in a pandemic situation to have domestically produced vaccines, because countries would nationalize their production facilities, and you worked on building that facility in North Carolina, the recombinant facility. And in fact, countries have nationalized their facilities. We've seen that behavior. But maybe for some of these commodity components, it's also important to have domestically sourced manufacturing, even things as simple as masks. And I think we're going to think differently about that going forward. And you can build that into legislation.
Yeah, a lot of things we're going to think differently about. In the minute we have left, the types of tests that are available, you mentioned moving away from just relying on the PCR lab-based tests for detection to more point of care, more self-administered tests. You also talked about getting better at the serologic test, to have a good understanding of not just population exposure, but confidence about immunity. Any final comments on that before we wrap up?
On the serology, I mean, I think that those tests are going to, I would expect them to be cleared by FDA. I've heard from people who have been approaching the agency, and these are sort of simple technology. We should get these things onto the market. I think the key to that, and you and I have talked about this, is going to be trying to do the serological testing at scale in a way that it's layered in the background, so we don't create another complex testing system. I mean, there'll be studies that are done that try to get representative samples to get a sort of statistically valid sample about what percentage of the population in different parts of the country have been exposed. But that's not going to be what we need to do. We need to do this at massive scale, where we have much more precise data about trends, how it's changing over time, as well as background immunity and inform public health decision making. But again, this is eminently achievable. And in a time that we're spending $2 trillion to try to weather this for a month, and we're going to have a fourth stimulus plan, we're talking about a relatively modest investment to build out a massive surveillance system that will serve us well, not just in this situation, but create capacities that will serve us well for years to come.
Scott, thanks for a very efficient overview of the issues we're talking about today, and for all your work you're doing on the pandemic. Really appreciate your being with us, and say hi to your friends in the background there. All right, I would like to turn now to our colleague from the FDA who's joining us today. Tim Stencil directs the Office of In Vitro Diagnostics and Radiological Health at FDA. I think Tim will be coming up on the screen in just a moment. Tim has been at the center of the steps that Scott was just describing around bringing more and better COVID-19 diagnostic tests to the market. I think we may have a little bit of a technical issue in switching to Tim. One of the things that while waiting for Tim to come up, I did want to highlight some of the recent steps that FDA has taken and the Office of In Vitro Diagnostics in particular has taken related to accelerating access to COVID-19 diagnostics. There have been recent guidance and revisions to guidance put out by the office that enables us to get to better testing faster. We'll be tweeting about some of those resources that are available. I think Tim would want to say that for anyone who is in the process of developing a diagnostic test and making it available, the FDA really wants to hear from them early to provide some technical guidance and feedback on the process for getting through FDA approval, for demonstrating effectiveness, and that sort of thing. We will have some of those links to the FDA resources up on the screen. So I'm going to just wait one more moment here to see if we're able to get Tim onto the screen. If not, I might call an audible here. See, Lauren Silvis is with us, who is going to be joining us on the second panel. Lauren, this may be a surprise for you, but I was hoping you could perhaps stand in for Tim a little bit and talking about some of the recent steps at the Device Center to facilitate innovation in the diagnostic testing capacity. So while we're waiting for Tim, maybe Mike, if we could pull up Lauren to join us and say goodbye to our former and current presidents on the screen there now.
Okay, can you hear me okay, Mark?
Yeah, I can hear you just fine. See, Tim.
Okay,
Thank
great.
you for joining us. And the way these things go, sometimes we need to do some last minute adjustments while we're working out the kinks. But Lauren is currently no longer at the FDA, but is Senior Vice President of External Affairs at Tempus, which is a company that is involved in advanced diagnostics, mainly in the cancer space, bringing together new sources of information and ways of interpreting it to help improve patient care. Formerly, Lauren served as Deputy Director at CDRH and Chief of Staff at the FDA. She's a co-author of the recent Duke Margolis report on advancing diagnostics that Scott referred to, as well as the recent Wall Street Journal op-ed with Scott on this topic. Lauren, could you say a little bit more for our audience about the role of CDRH and the Office of In Vitro Diagnostics at a time like this when new diagnostics and access to diagnostic tests are so important?
Sure. Well, I know that CDRH is looking at this in terms of, broad laboratory testing. So they, recently in their webinars, they've talked about policy A, policy B, policy C, and policy D. I mean, they're really getting in there and saying, here's what big labs need to do. Here's what manufacturers need to do. Here's how we're looking at point of care testing. Here's how we're trying to support the states. I mean, it's a all hands on deck kind of approach, understanding that the laboratory diagnostic system is complex. I think also as we get to the later panels, we'll see that what CDRH is trying to do is provide guidance to labs and manufacturers about what parts might be interchangeable so that we can have sustained testing capacity over time. So they're sort of identifying, based on their knowledge of all the different manufacturers who come in and the labs that they've been working with, about what parts might be able to help us surge the supply to get at some of the concerns that Scott was talking about, that we can sustain the testing capacity that we need. So they're looking at it on all fronts, and I think really updating their frequently asked questions almost every day with new and really specific guidance for labs and manufacturers.
Yeah. And just to pick up on the point that you made about interchangeability. So Scott brought this up too, for swabs, especially if we're trying to move to large scale testing that's done in a more convenient setting. It would be helpful if the swabs and associated materials that were used in a test could be used across multiple tests. And that's something that goes beyond individual manufacturers, right?
Yeah, and they're, CDRH is saying they're willing to look at bridging studies. They're willing to look at pooled data. Trying to have cross validation across platforms as much as possible. Because one of the things that we saw in the beginning is that labs have different PCR systems, and you want to use the system that you have. So you can either launch it as an LDT or wait for the kit from your manufacturer. So we saw Roche and Thermo and the Qiagens of the world coming online, and that allows more hospitals and more labs to be able to do the testing. We hope to see the same thing with point of care. Cepheid and Abbott were great steps, but what we hope to see over the next few weeks is other systems that are already sitting in doctors' offices. Like BD is a big system that also does rapid flu, rapid test. They've said that they're hoping to pursue an EUA for a point of care diagnostic in a doctor's office. So the more we have the different systems available, the more we'll be able to have more widespread capacity.
Yeah, so a couple of follow-ups on that. One is that FDA has taken steps through these emergency use authorizations that you've highlighted to essentially let people start using the test very rapidly. Do you see any concerns around getting data maybe after these tests are out and on the market and used to confirm that the sensitivity, the specificity, the reliability of those tests are where they need to be for effective use? How can CDRH help make sure that the tests that are being approved so quickly really are having their intended effects in practice?
If you look at past EUA diagnostic scenarios like Ebola and Zika, you'll see the tests improve over time. You'll see the test, number one, add additional supplies into the chain, and you'll also see their performance get better. I expect to see that here. Those EUAs have evolved over time, because remember, the original benefit risk calculation is, at this point, something is better than nothing, something that works well enough and can help us detect, the larger viral loads. As we get to, more widespread testing, you'll probably see the performance increase. And I expect some of the larger manufacturers' EUAs to, reflect the iteration of their tests improving.
Yeah, and along with that, we're seeing, as you said, more movement to tests that are more convenient, that are faster. A key part of that is people being able to administer the test themselves, and saw an approval last week, an emergency use approval for self-swab technology with United and in a Gates-funded effort. FDA has been a little bit reluctant about at-home testing, however. So that recent self-swab approval was for under supervision or in the context of visiting a drive-through facility or something like that. It still is an important step because it reduces the need for personal protective equipment and close contact between the health professional overseeing the test and the patient. But FDA does seem to have some concerns about tests being done in the home, not under that kind of direct supervision. Can you talk a little bit about that issue?
Sure. Well, I think that, they have said they'd like to see additional self-swabbing options, not under the direct supervision of the healthcare professional, what they've said now. But in order to do that, they need to show that people can collect a good enough sample, that the sample maintains its integrity, that it gets to the right place in time in order to generate an accurate result. If someone can demonstrate that and bring the data to FDA, they've said they want to work on that and expand that option. But I think the secondary concern there too is, thinking like an FDA, or you're always thinking like, who is the test for, right? And at every point in this chain, we've been limited in terms of who the test is for by our testing capacity, right? First, it was, travelers from China. Then it was people with symptoms and extreme symptoms and direct exposure. And then, what you saw was that people who could engage in self-care at home and it wouldn't change the course of their clinical care, they weren't able to get a test because we're always, limited by capacity. And so I think that in terms of having an at-home option, we'd still want to make sure that it makes sense in terms of like a public health tool and who is getting it. I think it is a critical step to have more widespread availability in order to get to the testing of asymptomatic or mild patients, so that we have the ability to immediately contact trace and do the isolation. So I think once we get to having more widespread tools, it will be an important part of the arsenal to prevent the future outbreaks.
So it seems like next steps will be, as you said, companies or innovators in this space working with test developers being able to demonstrate that the sample can be collected reliably, gotten to the testing facility appropriately, and the results shared back effectively with the patient as well as the healthcare system. But along with that, probably a need for some physician or clinical supervision, prescription. It doesn't sound like the next step is going to be sort of broad availability of over-the-counter testing in this space.
Yeah, I think you'd see a telehealth model before you got to any DTC.
Mm-hmm. And in terms of the other kinds of tests coming along, I just want to make sure our audience is fully with us on the two big dimensions that we're talking about. So we're talking about tests for detecting active COVID-19 infection in patients, both to help with their treatment and to help with isolation and control of spread. But we've also talked about so-called serology tests for evidence of prior exposure and an immune response in a patient to a COVID-19 infection. There has been more attention on the former category up until now, but we're starting to see some real innovation taking place in this latter category around serology. Scott alluded to some tests, at least in high-risk settings, suggesting that there is actually fairly high exposure to COVID-19 in some populations. Right now, I'd say we don't have a very good handle on just how wide population level exposure is in any population in the United States. So that kind of testing to know what kind of immunity is out there is important at the public health level, the population health level, for assessing the risk of a future outbreak in a region. It's also going to be increasingly important, as Scott highlighted, for identifying people who do have immunity and can potentially serve in more broader roles without so much concern in the future about being part of the spread of a future wave. Both of these areas fall within the in vitro diagnostics center. Do you feel like the guidance and the interaction with FDA is strong in both of those areas? So I just want to make sure that we're getting the right message out now about if people are developing tests in these areas, they should be working closely with the FDA, and the FDA is there to help to move these tests along quickly.
Well, on the serology testing, actually, FDA is not asking for those to come into review right now, as long as they put in the labeling that FDA has asked for, which is basically saying it's not a diagnostic tool and that it hasn't been evaluated by FDA. So they're making that available to the extent labs can develop it, and to the extent there are some kits available to do it, and saying, you know, they'll have that available as needed, but it's not at a large scale yet. Whether that becomes a large scale public health tool and they want to look more at the performance, or at least give guidance in terms of what sort of performance and validation they want to see, that could be a next step for them. But right now, I mean, I think they're pretty clear that those don't need to come into FDA for EUA. And it looks like Tim is going to join, so I'm sure he'll want to pick up on that point.
Okay, great. So Lauren, thanks for standing in. For those of you who are on our panels, I'm going to spend a few minutes with Tim, so we'll be starting a little bit late for the first panel, but we'll make up some of the time. Got some great perspectives from Lauren already. Lauren, thanks for this short notice duty, and let me go to Tim right now. Tim, if you are with us, Tim is as I mentioned, the head of the Office of In Vitro Diagnostics at FDA, one of the most busy people, I think, in the national and global response to the COVID-19 pandemic, because your office is the central point for this innovation and availability of needed tests. Tim, I'm not sure how much you were able to hear of the previous discussion, but I'd like to open it to you for comments about what you're seeing, what you think is most important right now. Thanks again for being with us.
Can you hear me?
Yeah, I can hear you just fine.
Oh, great. Sorry about those technical difficulties. Glad I'm on. Yeah, I was listening to it. It's great. I mean, we really welcome all test developers in this space to help out. And we're actually looking at non-coronavirus test development as well. If you think something other than directly detecting coronavirus is going to be helpful. As far as serology goes, we're going to probably be granting our first EUAs for serology this week. And as far as home use, we are very open to home testing, whether that's testing performed entirely in the home, and perhaps sometimes this is under telemedicine, as may be required, or the sample collection is at home and is sent in. I can talk a little bit about Lauren did a great job, so I just sort of want to cover some of those areas that perhaps weren't covered.
Please.
And that is that when we look at home testing, we want to make sure that whatever goes into the home is safe for home use. There's no poisons. There's no way that somebody might accidentally injure themselves. Maybe that's on the sample collection side. And then we also want to make sure that in the home environment, the test results are accurate. So those are the two important features. One of those accuracy measurements is to be able to ensure that a sample collected in the home, say, and shipped back to the lab is able to sustain that shipment and be stable so that you don't get a false negative result when the sample comes back to the lab, because that would be very unfortunate if that was the case. So we are working with a number of developers right now, and we hope to be able to give the green light to that in the near future.
Great to hear. And in terms of we talked a little bit about, so that's some next steps on testing for active infection. We talked a bit about serology and testing for immunity, and Lauren highlighted some of the steps that FDA has taken to provide, to encourage broad access to those new tests now. How do you see regulation and the role of your office evolving as these serology tests become more widely available and potentially much more important in tracking the overall risk in a region for a further outbreak and for helping to reliably identify people who do have immunity?
Sure. I mean, and since early January, we've been open for business on test developers here. And we opened up a pathway for these. Many of them are rapid finger prick type tests that can be done in a CLIA-waived sort of point of care setting, and can be widely distributed. And these are available in quantities that are in the millions. And they're free to market now once they've notified us. Last count I had was we were over 60 of these test developers have notified us and intend to market in the U.S. As we go forward, and we want to make sure that that we can give great information back, those that are interested can come through our normal EUA pathway, and we can give explicit and clear EUA authorization to those tests. I hope that addresses your question, Mark, but we see this as an important tool in managing the measurement of immunity.
It seems like a very important tool for that. Before we wrap up, just a bigger picture question. You're really getting slammed, which is a good thing that there's so much going on in the way of development. Do you feel like you've got the resources you need? Are there more steps that that the broader community could be taking to working with FDA effectively towards this goal of much better, wider spread test availability?
From the very beginning, we've been working with all of our federal partners, the CDC, BARDA, ASPR, CMS, and that's been a tremendous resource. Some of those entities have been made available the virus in patient samples eventually that are so necessary to be able to determine the accuracy of this testing. Our lab, our office is very expert in these emergencies. We've handled many of them before. Now, this particular emergency is the largest probably in our lifetime. And we have called in not just the rest of our office where needed, but also the center and the agency. And the agency as a whole has really come together and came together rapidly and has stepped up to assist us in all ways. So it's really been an all hands on deck situation to handle these. And as you see, we now have over, I think, 22 EUA authorizations. We've worked with more than 230 developers. More than 120 labs have already notified us that they're up and running with their LDTs. So, it's been to date, things are really looking up, and we've been eager to work with.
Great. Thank you very much. Any final thoughts, pieces of advice? I assume for any test developer, if they're not already in touch with you, it sounds like the door is wide open to help them get their care, get their treatment get their test to the market. I think we may have lost the audio there. Tim, I want you to it sounds like you can hear me, but I'd like you to be able to get back to work as soon as possible. Really appreciate your joining us today. Thank you very much. All right, we're going to go now to our first panel. This is a panel focusing on the short-term issues that we're facing in the availability of testing as part of this critical surge response to the big wave of the virus, the COVID-19 spread that's happening. Maybe at this point we could go to our first panel on the screen. So that would include, I'll go ahead and introduce them. Nicole Lurie, who's a consultant for the World Bank and the Coalition for Epidemic Preparedness Initiatives and former Assistant Secretary for Planning and Response at HHS during some previous epidemics. Second will be Betsy Nabal, who's the president of Brigham Health, been a national leader in the healthcare provider community and is an integral part of the response of the COVID-19 epidemic in the Boston area. Then Sumi Saha, who's senior director of advocacy at Premier and has been very involved in Premier's efforts to shore up supply chains and access to treatments. And access to needed materials, including diagnostics, but other supplies for hospitals and health systems. And finally, and last but not least, Mark Stevenson, who's Executive Vice President and Chief Operating Officer of Thermo Fisher Scientific, which is one of the leading diagnostics and medical equipment manufacturers, has been playing a major role in improving test availability in the COVID-19 context. So let me just pause here.
Hi, Mark. Mark,
Yeah.
this is Tim Stenzel from the FDA. Sorry, I got dropped. I'm going to hang on in case you want to ask me any questions, but I won't mute.
Okay, thank you very much. And hopefully we can get our other four panelists up on the screen now to start this next discussion. Okay, if we're not going to gallery view, maybe we can go back to me, and then over to my first question, which is going to be to Betsy Nabal from Brigham Health. So I think everyone in this country knows we're in the midst of a surge response to the epidemic. I'm wondering, Betsy, if you could start us off by talking about the situation on the ground where you are. I know you're dealing with the surge response in the Boston area. Maybe you could comment briefly on that and some of the activities you're taking to address testing needs in that context.
Great. Okay, thank you very much, Mark, and it's great to see and hear you, as well as the other panelists. So what I'd like to do is just give you a feel for what it's like to be on the front line at an academic medical center. Let me start out by a little bit of a timeline. So as we all recall, January 21st, first case in the United States was announced, a traveler from China. March 2nd was the first date at which the Brigham and the Mass General received permission from the FDA to develop a diagnostic test within our pathology lab. We literally lost 6 weeks, and we were ready to go develop our in-home house testing. We lost 6 weeks in testing, tracking, and quarantine. Extremely frustrating for us, extremely frustrating for our patients. Because of CDC and FDA guidelines, we were forced to test through our Massachusetts Department of Public Health, which wasn't prepared, did not have the testing capacity, lacked kits, and had several week turnaround times. So we were in a no man's zone there for 6 weeks until March 2nd. On March 2nd, our pathology labs at the Mass General and the Brigham started working together under the leadership of Dr. Jeff Golden, Dr. David Lewis. 1 week later, on March 9th, we stood up our SARS-CoV-2 RT-PCR diagnostic test. We began testing about 100 patients a day and quickly have ramped up now to about 400 tests a day. Over the past couple weeks, we in the MGH, we're part of one collective health system, have collaborated in developing multiple testing platforms. The reason is that once we set up a single platform, we ran into testing reagent shortages, initially some of the Taq polymerases, for example. So we need to have multiple platforms running in parallel, and this is an incredibly important lesson. And I do want to do a shout out to Thermo Fisher because they've been absolutely phenomenal in helping us with testing supplies. So what do we have currently going on between the Mass General and the Brigham? And we are doing our own in-house testing now for our partners' healthcare system. We're using a Roche system, the Cepheid system, and the Hologic system. We have duplicate platforms in both pathology departments. We've now found we at a certain point had a shortage of the viral media. We found that we can use saline just as well. We started doing 3D printing of swabs because there was a shortage of swabs for a period of time. We found that has helped us as well. During this transition, we continued to use Quest and LabCorp, but their turnarounds were long, 5 to 7 days. And the reason that's really unacceptable is that we have admitted a number of patients who are under suspicion for having COVID. They're occupying hospital beds, and we need to quickly determine if they're COVID positive or not. So currently with our in-house lab testing, we have turnaround within 24 hours, which helps us clarify if patients are positive or not. So the second area of focus for us is assisting our state to build capacity for health systems across the state of Massachusetts. As I said to you earlier, we were initially required to work through our Massachusetts Department of Public Health, who simply didn't have the staff or the capacity. So what we have done is worked with the Broad Institute. Many of you are familiar with the Broad. The Broad has been doing CLIA-approved high-throughput genomic screening for decades, and recently have turned their attention to high-throughput COVID-19 testing. So our pathology chairs and departments have worked very closely with Eric Lander and Stacy Gabriel to put this conversion into place over the past 2 weeks, including operational details like getting a license, workstation logins, EHR reporting, and really setting up a statewide testing system through our state incident command center on the website. So Broad Diagnostic testing is now in place with the capacity of doing 1,000 tests a day, hopefully building up to about 2,000 a day. As I said earlier, for our own health system, we're probably doing the largest number of any health system within Massachusetts. We're trying to do them all in-house so we can save the Broad for the other health systems across the state, particularly the smaller community hospitals. So our third focus is, as you started to discuss, is on serological antibody testing. Again, we are a number of innovations. We're both working with companies as well as developing our own serological testing. We hope to have that up and running within the next week or so. Our goal is really to identify those within our community who've been infected. It'll help us understand the epidemiology of COVID-19 within our community, help us predict a potential second wave, and really, really importantly, help us understand when we can have our staff safely return back to work, those that might be redeployed. In terms of testing, we talked about community testing. We have set up testing sites throughout all of our community ambulatory sites. These are drive-in tests. The tests then get done in our academic pathology labs. At the present time, as we build capacity, we have set testing criteria. Our first criteria goes to symptomatic inpatients and symptomatic healthcare workers. As we get through those in a more rapid turnaround time, we'll be able to expand the numbers that we can test. We clearly want to be part of the public health surveillance system and look forward to a time when we can collaborate with other health systems to do that. So what are our challenges right now, Mark? It's maintaining the supply chain. We've got the testing equipment in place, but it's the reagents and the swabs. We want to fully develop antibody testing. and it's really maintaining, interesting enough, the PPE pipeline, because our PPE has to go obviously towards our frontline care providers, but we also need PPE for people running, doing the testing, running the tests within the labs. And I think most importantly, we're really focused on working with our state officials, our state incident command center, to coordinate testing supplies and ensure that testing is available on an equity and a parity basis throughout our state. So thank you very much.
Betsy, thanks for that tremendous overview. And I really appreciate your taking the time to not only spend with us, but think about the whole path forward while you're dealing with a real crisis in Boston right now. So thank you. We're going to come back to these next steps. Let me go next to Sumi. Sumi, you heard the challenges that are emerging now with more tests becoming available. It really is those reagents, the other supplies that are essential for completing a test that are becoming more of an issue. What are you seeing on that and any other big challenges right now from your standpoint? You are involved in supplying a wide range of hospitals and health systems around the country.
Great, thank you, Mark. And so Premier is an organization. We consider ourselves to be a supply chain leader. We work with over 4,000 hospitals across the country, as well as about 175,000 non-acute providers such as nursing homes, skilled facilities, etc. So I want to discuss two different points here. So Premier did survey our membership last week. I want to share some of those results from that survey that are specific to lab diagnostics and some of the shortages that our members are facing, and then also switch to some recommendations for how we can see expanded availability of some of these supplies. So we did field a survey between March 16th and 20th. We had 1,591 hospitals respond to that, which represents about 32% of all US hospitals. Of the respondents, 42% did have live COVID patients, and 41% of those did have lab testing capacity. So a couple different things to note here. So when we think about reagents, 23% of respondents noted that they are having difficulty obtaining the appropriate reagents. That 23% represents those that do have live COVID patients in their institutions. For institutions that did not have COVID patients at the time, 16.3% reported a shortage of reagents. Now, if we switch to the viral swabs, entities that did have COVID patients, 56% reported a shortage of swabs, whereas 39% of entities that did not have COVID patients reported a shortage of swabs. We also did some analysis on what is the average day on hand inventory for these swabs. So across the country, we were able to calculate that a typical hospital that has lab testing capacity has approximately 10 days of viral swabs on hand. We also looked at what was the viral swab utilization before a hospital had COVID patients versus afterwards. And we calculate that out to be about a 6-time surge in use of swabs once COVID patients do appear at the hospital. And we also found that the biggest risk for shortages for these viral swabs are the medium-sized hospitals. The average medium-sized hospital surveyed only had about 3 days of inventory on hand for these viral swabs, compared to 10 days on hand, which was the national average. So a couple other data points here. At the time of the survey, 56% of respondents had stood up drive-through type of lab testing. I think in the past week or so, several of those entities have noted that they have since shut down those drive-through facilities due to a shortage of not only reagents and swabs, but also PP as well, to Betsy's point. We've also seen 61% of entities now limiting testing. So in lieu of broad testing, we're seeing testing limited to certain patient populations, such as those that are immunocompromised, elderly, or are otherwise high risk. One other thing that Premier did was look at the geography. Where are these swabs currently located in the country? And interestingly, a lot of these swabs are located in states such as Minnesota, Montana, Nebraska, Kentucky, West Virginia, South Dakota. So is there an opportunity to shift available supply from states that may not have an immediate threat of an outbreak to certain hotspots that have a greater need? We don't anticipate that being a long-term solution, but can it be leveraged as a Band-Aid in the interim to provide broader testing to those areas that are those hotspots or those emerging hotspots? So switching from survey data now into some of the recommendations. So, one of the areas that Premier's really been focused on is how do we increase capacity for the viral swabs? And when you look at what was CDC's ideal recommendations for the viral swab, you're looking at something that is a nasopharyngeal, it has to be a synthetic fiber, that is flocked, no calcium alginate, and no wooden shaft. And the reality is that there's unfortunately only one manufacturer globally that meets all 5 of those requirements, that manufacturer being located solely in the country of Italy. Now, with increased global demand and the disease progression in Italy also creating strain on the Italian manufacturing marketplace, what we saw was an immediate shortage occurring in the United States. Now, starting last week, the US does have 3 military flights that are flying to Italy to collect approximately 1 million swabs per week and bring them back to the US. I will let you know that from the hospital perspective, there's a lot of confusion still around, are those swabs arriving domestically? And if yes, how are they being distributed? Are they going through the Strategic National Stockpile? Are they going into traditional distribution channels? How do hospitals get their hands on additional viral swabs? Another little known fact is that those viral swabs from that Italian manufacturer are currently patent protected. So simply ramping up domestic manufacturing of those swabs is not a viable option because of the intellectual property rights. So a couple things that Premier really recommends is that the US look at how we can overcome some of those intellectual property rights to increase domestic manufacturing. We do think that there's 3 legal pathways that the US can consider. So one would be the trade-related aspect intellectual property rights or TRIPS bill, where IP requirements can be waived in a national emergency or health crisis. The second is 28 USC section 1498, which allows the federal government to exercise eminent domain authority over intellectual property rights without prior consent of the patent owner. And the third option is if this manufacturer is a federal contractor, can the United States exercise its patent march-in rights under the Bayh-Dole Act? So we do think an opportunity here is for the US to declare a compulsory license permitting the domestic manufacturing of these products, or to permit others to manufacture similar swabs that meet the CDC requirements. Just 2 other quick facts. From a survey perspective, 58% of respondents indicated that they have started receiving gray market offers specifically for PPE. In the past week or so, we started to see an increase in gray market offers for viral swabs and reagents as well. We really need to be careful there that these products may be adulterated, counterfeit, or mishandled. And so if we cannot solve some of these shortage issues, we really want to be mindful that hospitals are not leveraging or going to these gray market opportunities that may not prove to be as effective as the real deal, if you will. And then the only other ask that our hospital partners have is FDA and CDC have done an amazing job at trying to identify alternatives to Betsy's point, such as saline as a transport medium. And the FAQs are updated frequently, but absent proactively going to these websites and trying to identify what the updates for the day were, it's very difficult for hospitals to get that information fed to them. Since at this time, they are so focused on being on the front line with patient care, anything that we can do to create a more transparent communication channel regarding any changes or new alternatives would be very welcomed. So with that, thank you.
Thank you very much for that overview of where things stand now, as well as some steps to address the challenges, especially around test materials. I want to come back to that, both about more clarity around where hospitals and other healthcare providers can identify the sources of supply they need, as well as further steps to increase the supply of those materials. On the way to doing that, I'd like to turn to Mark next. We've already talked about Thermo Fisher, Mark, in a few contexts, both in terms of being some of the early participants in bringing new tests through FDA for emergency use approvals, and then second, for helping with the surge in places like the Brigham and all over the country. So Mark, your comments about where we are and where we're headed right now in dealing with the surge in need for diagnostics.
Well, yes, Mark, thanks. And thanks for bringing everyone together. I actually been interacting with many of the people on the video and the phone here, so it's great to have us all together talking about common issues. You know, from Thermo Fisher side, we approached it in multiple different ways. We saw in China in January this really take off with many components, our instruments getting pulled in there, our components, our reagents, as the CDC, as the World Health Organization started to use components. We'd previously been involved in Zika and Ebola and other outbreaks, so it's very common for us to get pulled into these situations. We also have Fisher Healthcare in the US, which distributes, as Premier does and Premier we work with in these areas, so quickly got into the backlog that Sumi just described in that way. You know, from our side, we then developed an assay. We did initially focus on that as the area. I take Scott's comments, that's also typical where the diagnostic manufacturers work together. But we wanted to make sure we could bring the components into an assay, that we could make it at scale. And then we came to Tim Stencils and his team, a very collaborative partnership with the FDA, worked incredibly well. We focused on our install base, where we thought, look, there's about 200 labs already across the US that had the install base, so we focused on that base first. We focused on giving a sample prep solution so the whole thing was integrated and that we could manufacture at scale. Scale for us is about 1 million tests a week. We announced that we would go to 2 million tests a week, which we've already achieved, and this week we'll be at 5 million tests a week. So we're trying to keep pace with the virus, doubling every week, in that we're going at that rate and doubling. You know, the FDA has been incredibly helpful, as well as we've filed additional extensions, because we're moving from the first install base to add another 1,000 of the instruments to give us more flexibility on the sample prep, as well as working with other groups. It turns out the swab is an issue, and you know, rightly done. We actually have converted some of our manufacturing to transport media. So we have other teams that are making microbiology media that we've, in Lenexa and Kansas, we've converted into making transport media. As Sumi pointed out, with flu testing, there's often gone on a point of care, and so the use of swabs has just increased massively, and also the transport media. So we're scaling that up, as well as large scale, and trying to balance that with them bringing that data back. It's been helpful also with Gates Foundation to examine different areas, different swab types, foam swipes. You know, some of these patients, when we measure on qPCR, we're getting 10 to the 6 viral load. The sensitivity limit of detection is something like 10 copies of the virus. So there's a lot of room there before we're getting, at the moment, we're not seeing false negatives coming through, but obviously we want to make sure as we bring on this testing capacity and bring the data to the FDA, it's safe and effective. Yeah. So look, what are the shortcomings we've had? You know, certainly collection kits and extraction. You know, we are scaling up, and some of our, you know, you heard from Betsy, some of the work we're doing, like at the Broad, is how can we scale up the sample prep to be at manufacturing scale, industrial scale, which is what some of these genome centers are working at. And in the past, that wasn't something that was mentioned that was sort of strategic stockpile. And so that's certainly, I think, a takeaway for all of us. You know, the other thing we found, and, you know, our approval was on March 13th, and that day I was at the White House and sort of looked and thought there'd be a more federal approach to this. But actually, since that time, what I've observed is, you know, maybe you can tell from the accent, although I've been in the US 20 years, I'm originally from the UK, getting used to the sort of federal and state nature of the US structure. I'll give you the example from my own home country. So in the UK government, what we did the following Monday, we set up to work with the National Health Service to stand up one lab, which we announced this last weekend would scale up. We're scaling up to do 100,000 tests a day. We're going to stand up 2 more labs. And what we decided to do then, coming back to the US, is try to replicate that statewide. So we picked 10 states, and out of those 10 states, we're focused on originally where the hotspots were. Like you've heard with Massachusetts, we're working with New York, New Jersey. We've picked those states and try to then go to the public health labs and to say, well, how can we coordinate? What happened in the US, and we're doing this in the UK and with some of the states, is the Army helped take some of the instruments out of other labs that were now redundant at the moment, put them into this central area, and it coordinated the scale up of testing. And so we've done that, for example, in UCSD. We're now standing it up in UCLA. And that's where I think we could help with some coordination. I'm learning that state by state, that helps. But even when we get to small states, I'll give Rhode Island as a state, we'll get demand from the governor level, the city level, the lab level. And that's not very helpful. We need to somehow coordinate, because we need to make sure the inventory goes in actually as they can accept the inventory, and not that it's sitting in state warehouses or stockpiles at this point. So those are some of the issues that we're working with. I would just finally say, as we sort of look towards, the fall, I appreciate what Scott's looking for. I think another issue we're looking at is, how do we get data collection in the right way? How do we have the sort of IoT of the instruments reporting back? We've also now got other countries ramping up. The Africa and the subcontinent is ramping up as we come there. So how do we think about the approach for some of these less resource-rich countries that's also going to start to pull on our demand of manufacturing, which for us globally comes out of the US?
Yeah, Mark, great points. And I think on these issues of clarity about access to supplies and where they can be obtained, around the increase in testing capacity and supplies associated with it, which you've been playing a critical role in, and then looking ahead to how to actually do effective surveillance and more population-based testing in a country does have a federal structure like ours, that does have a role for public health surveillance at the local and state level. All important issues ahead. And Nicole, I'm going to turn to you now, because this tees up a good set of issues for you to talk about. So in your previous work as Assistant Secretary for Preparedness and Response, and for coordinating some of the U.S. activities for public health emergency medical countermeasures, you obviously had a lot of experience in dealing with previous epidemics. Thoughts about where we are and where we should be headed from your standpoint in terms of a federal role in supporting these efforts? I think you may be on mute. Okay, we seem to have lost Nicole, so let me go back to the participants in this group to talk about next steps. So I just summarized several areas where I think we can and do need some further efforts. One is around clarity on where supply can come from. A second is around continuing to increase sources of supply, and third is building this surveillance system. Maybe we could go to some of the discussions that Betsy, you and Mark highlighted around bringing in some additional sources of support for developing and conducting tests. Mark, you mentioned 10 states where you're engaged in some pilot efforts. That sounds like what Betsy was talking about in Massachusetts with the Broad Institute. Can you say a little bit more about how you see that unfolding in the days ahead?
Yeah, what we're trying to do is decide how to prioritize supplies into the states, and it's helpful if we've got a efficient consumption system going on. So what we don't want to do is put supplies in where the consumption. So what we've been trying to do is reach out to leaders in each of the state, and that's why Betsy actually was probably incoming as well, because our CEO and Betsy know each other very well. So we get some incoming, we get some outgoing. But I guess the question I have also as we look at this group, is that the best approach? Some states cities are better organized. The healthcare system in Boston, is all very well connected and speaks to each other. As I work with some states, it's very difficult to get in touch with the right people to coordinate. Originally, as I said, I thought that may be coming out of a central coordination, out of the White House or out of the task force. But as we think as an industry, collectively in the diagnostics, where should we focus that testing and capacity? We have also focused on the big suppliers. in the labs, in the lab cores and the Quest and the bioreference. But we're getting to a point, even with our scaling of manufacturing, where do we decide to ship these incoming swabs? Where do we decide to ship the incoming sample material? And I get a lot of people reach out to me and say, we're the most important, and I'm trying to pass through that. And so appreciate sort of guidance centrally, I think, is something we're missing.
Yeah, and maybe a bigger federal role in that. I know Nicole Lurie, who had intended to be on, but I think is having some technical difficulties, wanted to comment on steps that the federal government can take, not necessarily using the Defense Procurement Act, but with kind of a force behind it to get a better understanding of what kind of supplies are really needed from different places in the country, and to coordinate that with additional sources of those supplies. So I think we might come back to that topic, but it definitely is one that seems to have some room for further development right now as part of the response. I would also add that it seems to me that there are some private organizations, including all of you, working together that are starting to take that kind of role. But it's got a note from Mike Polini too, who you'll hear from on the second panel, that it does seem a bit siloed. So really a push around getting a clearer national understanding of supply needs and supply sources, and then taking the further steps like Sumi noted that could potentially increase supply seems like an important further direction too. Let me go back to Betsy, and maybe Betsy, you could talk a little bit more based on what you've heard about how you think things are going to move forward. Mark emphasized the importance of states and localities. I would agree with that. I was talking with, I just heard from Mike Levitt not that long ago about this federal state nature of responses, where the federal government can play a supporting role, set some goals, help coordinate, but a lot happens at the state and local level, especially when it comes to public health, local detection of cases and public health responses. So maybe a little bit more about what's going on in Massachusetts.
Yeah. Well, thank you, Mark. I think at this point, particularly for those of us who live within states in which we do have hotspots, and we're now on the ascending limb of the curve and anticipating a surge within a couple of weeks. We're in the midst right now of preparing for a surge capacity, and we're probably about 10 days behind New York City. So we have found it most effective to work in a coordinated manner across our state. We have an incident command center that our governor heads. We have daily incident command calls in which our governor, our head of Department of Health and Human Services, Mayor of Boston, other key state and local officials, as well as health system leaders participate. I think the good news is that if there's been one thing that has brought health systems together and encouraged us to coordinate and be collaborative with one another, this is it. So this is the new normal, which we look forward to continuing post-COVID-19. But I think each state and each region is going to have to handle it in the best manner that they can. And we found that just doing this as a coordinated manner across our state, all the health systems coming together collaboratively, is the best way to do it. We anticipate that if we get overwhelmed with the number of COVID positive patients, particularly in the inpatient setting, we're now planning for setting up field hospitals, low acuity COVID positive patients who are post hospitalization. We certainly may need to go to a state distribution system for PPE supplies, and particularly vents. I think the unfortunate piece, I know this is not about vents and those sets of supplies, but really the unfortunate piece right now is our governors are competing with one another and competing with the federal government to get access to vents and other supplies. And it's an unfortunate state, but it is where we are.
Yeah, and that gets back to the critical point about the federal government's coordinating role and identifying all of the needs out there and prioritizing them against all of the potential sources of supply. So hopefully we'll see more progress in that regard. But it is interesting to see states stepping up to more or less degrees. And I think, as you emphasized, Betsy, we are going to need a stronger, and Scott talked about this at the outset, a stronger state and local capability for doing testing at very large scale, for sharing that information. Mark mentioned Internet of Things, getting to perhaps lab devices for rapid sharing of information to be able to do effective surveillance and testing in the event of an outbreak, and to monitor local immune status as well. Let me go back to Sumi, see if you've got any comments to add before we wrap up this panel. We've covered a lot about where we are now and what needs to happen in the short term, heading into the long-term surveillance capacity. Do you see some future steps involving Premier in some of this?
Yeah, great question. So Premier has been working in direct concert with FEMA, as FEMA has been coordinating the government's response to this. And they've made great progress in the past week or so in really standing up a coordinated effort. I will say one challenge has been the immediate focus was on personal protective equipment and ventilators. It doesn't seem that the lab and diagnostic concerns have risen to the same level as part of FEMA's response quite yet. We hope to change that dynamic moving forward. I think lab is one of the first examples where it was very clear that the public could not do this on their own, that you needed private sector participation in order to really create a level of public-private partnership that increased capacity throughout the country. And so we're looking forward to really helping FEMA understand some of the diagnostic issues that are being faced by hospitals and labs across the country, and ensuring it gets the same level of attention that things like PPE and ventilators are.
I mean, it does seem like this is going to be the sort of the third wave in a need for national surge coordination and management. Totally understandable that ventilators and personal protective equipment are coming first, because as we've talked about, we are not at the stage where we're doing large scale community testing. Betsy, who's ahead of most, is still focusing on priority patients and on dealing with the clinical complications in those patients. But hopefully the steps that are being taken to improve coordination on these first two will carry over to what will be a needed surge in surveillance capacity to contain any further outbreaks and help us manage out of this one. Let me just ask any of our panelists before we wrap up this panel. I want to go to a comment or a reaction from Tim Stenzel before we go to the second panel. But any final thoughts before we wrap up here? All right. Well, thank you all very much for joining us. Great perspectives and great work that you're doing as part of this unprecedented epidemic response. Tim, you've heard from the front lines and from various parts of the healthcare community about what's happening now, what's ahead, what's being planned on building up diagnostic capacity for dealing with the pandemic. Final thoughts from you on these issues?
Thanks, Mark. It's been wonderful to be part of this. I appreciate the organization and the invitation to speak. I mean, from the beginning and through now, we want to work with all developers to help this situation. We want to be flexible, adaptable, deal with the issues on the ground, the spot shortages, all that we did with frequently asked questions. That was great. Looking forward to the future, we realize how important our commercial partners have played in really ramping up the testing. I want to call out a few that have really done a great job. Two that may not be well known, and they are IDT in Iowa and BioSearch in California. They helped us out very early on to rapidly expand. They also provide the core raw materials for many of the other test developers. I'd also like to call out Abbott, Roche, and Thermo Fisher. These five together have actually led to tens of millions of tests being on the market in a short amount of time. And finally, United Healthcare Group also was able to help us with validating nasal swabs. That was really important in expanding the number of swabs and anatomical sites. So again, thank you so much. Thanks to all who have interacted with us. We valued it, and we look forward to continuing to working with you to address the emergency. Thank you.
Excellent, Tim. Very, very well said. And thank you again for taking the time with us. So now we are going to start looking a bit further ahead, and like to introduce our second panel to do that. This is a session that's going to focus on strategies to maximize testing capacity. That's PCR largely now. We heard about the big response that Tim just highlighted there, as well as tests that move into point of care, as well as tests that rely more on self-administered settings and maybe even headed to home-based settings. We're going to try and cover these testing innovations in two areas: more rapid and easy testing for the presence of COVID-19 infection, moving again towards point of care and easier to administer tests. They're still reliable. And second, better testing for prior exposure and immunity, the so-called serologic test for antibodies to the virus. And our panelists on this session are Lauren Silvis, who I introduced previously, Mike Polini, who is a managing partner at Section 32 and very much involved in innovation and diagnostics broadly, Matt Sos, who's president and chief executive officer at Roche Diagnostics, has been a key part of the response so far and some of the innovative tests going forward, and Dave Pershing, who's chief medical and technology officer at Cepheid, who also the Cepheid work has already been highlighted and moving to faster and more widespread availability of rapid testing. So I want to start off with Mike. Mike, you've spent your career on innovation in earlier and more accurate diagnostics to improve care. Also know you're deep involved in helping to respond to the surge challenges that we've talked about here. Can you talk a little bit about what you see coming and how we can get to this set of goals around effective surveillance that Scott and I talked about at the outset?
Yeah, Mark, I'd be happy to. Before I start any comments, because this is live, of course, they just started doing road work outside of my house here. So if it gets too noisy, just let me know. But it started 10 minutes ago, surprisingly enough. They're drilling the road. And I do want to thank you and the Duke Margolis team, as well as Alexandria Real Estate, for all the work that you put in with these forums. These are the best forums in our industry. And I also want to take a minute to thank this group. Some are on the front lines, as we heard from Betsy. Some are on the supporting lines. But, just a big thanks to everything that everyone is doing, because let's face it, this is a group in healthcare now. Everyone is working extraordinarily hard. And so to your point about where things stand and where we're heading, while we don't necessarily have a national comprehensive plan, we do have a roadmap. And I really do want to come back to the roadmap that you and the team and Scott Gottlieb put out just a couple of days ago. It is the roadmap that we should be embarking upon as a country. And, I think just as a side note, amazing group of people with Caitlin and you, Mark, and Lauren and Crystal involved here. But, I do think Dr. Gottlieb should consider running for president in 4 years, with, I think, the education that he has given this country on the importance of action. We all owe him certainly some gratitude. So one last introductory point. We've heard a lot about the value of diagnostic testing from a medical standpoint, from an economic standpoint, research standpoint, from a planning standpoint. But there's another component of the value of diagnostic testing in the context of this disease. It's the emotional value from diagnostic testing as well. And what that means is, if you think about the number of phone calls, emails, and texts that each of us receive from friends, colleagues, family members, questions around quarantine, questions around isolation. I'll personalize it for a second. I'm a 54-year-old male. I have a fairly good understanding of this virus, of how to get diagnostic testing, of what I might want to do from a therapeutic standpoint. But if I spike a temp, I want to know if I have COVID or not. And there is an emotional component, because I will think differently if I test positive or if I think negative, or if I test negative. In addition, I have an 89-year-old mother. She lives alone. I would love to be able to see her at some point in the next couple of months. Because of this, because of this virus, I can't see her. My brothers can't see her. So I think as we contemplate these solutions, whether it's in large labs and academic labs, at the point of care, or even at the home level, we need to think about the emotional aspects and all the other things that are playing out in this country as well, which really does bring me to the topic at hand, We haven't had a pre-meeting call, so I don't want to take a chance that I'm going to overlap with some of the other speakers, specifically on point-of-care testing. But so I'll offer maybe more of a broad brush of comments. We need point-of-care testing and we need home testing. It's not an or. We need PCR and molecular testing and we need serologic testing. It's not an or. We need diagnostic equipment and technology, and we need other means like swabs and a focus on logistics. These things are not an or. So that's really the path that I'm going to go down. I'm going to focus on home testing, but in the context of all the things that we really need to be doing as a nation right now. So we are seeing the emergence of these home diagnostic tests. I'll point out something that's been really positive from the federal government. I'll come back to the FDA because they've been remarkably positive, but I think even the work that BARDA is supporting, I've seen them focus on innovative home-based diagnostic testing. I think earlier this morning they announced $13 million of funding for a San Diego company called Q Diagnostics. But I think we have to remember that even as we focus on this home diagnostics and on the technology that is being developed, developing the technology is only one part of the solution. I often say that we have to focus on on that red zone offense. You march all the way downfield, you have the technology ready to go, and then you forget about the swabs. You forget about the final pieces that we have to put in place in order for these tests to be utilized in the fashion that's necessary. So what does that mean? What do we need to complete the game plan? We need these tests to be validated. They have to be consistent and accurate, and we have to be able to validate these tests quickly. Number two, of course, they need to be approved by the FDA. If you hearing Tim's comments, hearing Lauren's comments, I mean, I think we all have confidence in the work that the FDA is doing. That's not going to be a roadblock. These tests need to be reimbursed. We need further clarity around reimbursement, especially when it comes to home testing. And critically, these tests need to be uploaded to a national database. So why do we need the national database, even in the context of point-of-care tests and home-based tests? Tests are going to have to be refined as we learn more about this rapidly evolving world and rapidly evolving, well, hopefully not rapidly evolving virus, but this virus in the context of our world. We need to understand the value of serologic testing. How long does one's immunity last after we receive the testing? How sensitive are these serologic tests? What is the T cell involvement that we need to consider? That's work that Adaptive Biosciences is doing. We need this database to be available for freely open research, both at the academic level and at the industry level. And so I want to plant a couple of seeds here. One is, I know it's hard to do. I know our statutes, our regulations make it very difficult to do this because I've talked about this in previous years, not related to COVID testing, but other testing. Payment should be linked to uploading results to a centralized database. Somehow we have to figure that out. So the payment comes after the results are uploaded. And that's just incredibly important to figure out. We have to mandate that, I believe, at a national level if it's really going to happen at the level that's necessary. If we do that, and if we have this national database that brings all this testing information together, it will help us get back to work. It will help us see our elderly parents. It will help healthcare workers and assisted living workers be able to go back to work to safely see their patients and safely see folks living in various settings around the United States. It'll help us treat patients. It'll help us triage patients, and it will help with surveillance. So in closing, I'm going to even bring it up to a higher level and say, I'm going to get on a soapbox for the last minute here, and it's just a focus on the value of diagnostics. Many of us have been fighting this battle for 20 years. I think the FDA battle is, that's behind us 10 years. The FDA has been wonderful. And I know we're still arguing in the industry about CLIA versus FDA. That's okay. We can have different opinions. Even with these different opinions, we're still making progress. But we need to focus on kind of what's happening with Medicare payment, especially the private payers. Because if you bring a therapeutic through the FDA and it's approved, it's going to get reimbursed. I know it's not quite that simple, and I'm not taking anything away from the biotech industry and pharma industry and all they have to do to make sure they get appropriate reimbursement, and frankly, all the work that Medicare and the payers need to do in order to assess the value. But we have nothing in diagnostics. We can get approved through the FDA, and that means absolutely zero for payment, and I do mean zero. So one of the reasons that we are in this mess is because we as a society think these diagnostic tests magically appear. They don't. And unless pharma comes together, unless policyholders come together, unless all of us come together to really change this paradigm, we're at risk that we will be in the same situation in the fall, as Scott said, or even later on down the road. So I think we can zoom in all the way to the value of home-based tests, and then as we continue to work out, really everything comes back to a critical point, and that is we need to re-examine the focus that we have, the value that we place on diagnostics in this country.
Great, Mike. Thanks for those comments. You brought some really important further issues around payment that I'd like to come back to, and especially payment, as you said, linked to actual results and impact on population health surveillance and preventing further outbreaks. Very, very important with test innovation in this area. Right now, I'd like to go to Dave. Dave, Cepheid quickly developed some more rapid tests for COVID-19. Been working closely with FDA on that. You're deploying more. You've got a whole supply chain that you manage for your tests. What do you see going forward? Your suggestions for how we get to this kind of future state that Mike and others have been talking about.
Yeah, thank you. So we got our EUA about 12 days ago, and we began manufacturing our tests last week. I'm not Carl Sagan, but I will say millions and millions are coming in the next few months. And we're just trying to keep up with demand at this point. We've positioned the test as a test for triage, really a test for bed management in hospitals, not for the worried well, not for outpatient testing yet. But we do see this potentially going in that direction in the future. As you probably know, we have a big footprint. We've got nearly 5,000 systems in the US, most of which are in hospitals, which can be deployed quickly for triage purposes. We have a fair number of point of care systems as well, running our CLIA wave tests. We're not necessarily supplying CLIA wave sites right now, but I think it's a fair question, and we should have this discussion about what's the future of point of care testing in the COVID era. At this time, there appears to be a fair amount of fear and uncertainty about doing testing at the point of care, given the infectious nature of the sample that we're collecting, the process of transferring the sample to the cartridges, irrespective of the platform. Most point of care settings don't have a biosafety cabinet in place, nor do they want to don PPE every time they collect a swab, nor do they want lots of coughing people in the same waiting area. Are we going to be looking at a different model for testing going forward in the upcoming respiratory season? I think that the concept of continuing the testing sort of outside the store, outside the pharmacy, in a mobile lab setting, for perhaps might be something we have to consider here, and that would be one way of dealing with the problem all the way around. I'm sure pharmacies don't want coughing patients inside the pharmacy walking the aisles. So they have an interest in providing a testing service that's nearby, but not necessarily in the store. So these are all questions that we need to wrestle with. You may also know that Cepheid has a pretty big global footprint. We have over 23,000 systems out there, most of which are testing for TB, HIV, and increasingly for cervical cancer. A lot of that is deployable for COVID-19 testing. We were on track to make roughly 20 million TB test cartridges this year. That could change depending on COVID demand. So we'll watch that closely, but the possibility exists also to get a lot of data from those systems. Several years ago, we developed a cloud-based software system called C360, which is really designed for instrument monitoring, to monitor the functioning of each module in the system, but also to gather data on test results in real time as well. This was launched initially in South Africa for TB test monitoring and drug resistance monitoring. We've gotten a lot of data from millions of tests performed in South Africa from that system. It is LIS and EHR independent, so it doesn't need to have that connection to be able to report those test results. We get positive, negative status. We get bacterial load data from those sites as well in real time. So it's potentially a valuable tool in terms of monitoring where new outbreaks are occurring and where cases are spreading. We do have a number of sites in the US that are connected to C360, primarily for flu RSV reporting. We get those reports at Cepheid, but our data use agreements with our customers are such that we're not allowed to share that data outside of Cepheid. Internally, we can see that we can track flu trends very accurately about 10 to 12 days in advance of the public reporting by CDC relative to downturns and upswings of flu activity nationwide. Even though we have a small number of sites that are connected, we're still able to predict quite accurately what the flu trends are. We might expect the same thing from COVID-19 testing as well. But the emphasis now is trying to increase the number of sites that are connected and to modify our data use agreements to allow us to share the data with CDC, APHL, and with local laboratories to be able to monitor their cases more closely. In terms of self-swabbing, I have a few comments. I think I think it's very important to increase sample type and sample location options. Swabbing under supervision is different from unsupervised swabbing. We've seen this with chlamydia self-sampling, that some patients are very motivated to have a negative result for whatever reason. So the air swab is a real phenomenon that's been described on the internet. So does the swab get to the right place, and does it collect an adequate specimen? It's a fair question. There are things that we can do test development wise to actually accommodate the variability in sample collection that might happen. We can build in a sample adequacy control, as we have done with our chlamydia gonorrhea test and our HPV test, that are designed for monitoring the efficiency of self-sampling. We could also monitor self-sampling at home by video, potentially as well. So I think there are going to be challenges with self-sampling at home, but I think they can potentially be overcome. The other option that's come up recently is a saliva specimen as a possibility. Some work coming out of Hong Kong suggests that a vigorous throat clearing followed by spitting into a cup is actually a pretty good option for sampling and for monitoring patients on therapy. That might be something that we could envision in the future as as a less swab dependent option. Nasal washes are already on label, but they have to be collected by a provider. So that might be a reasonable self-sampling option to collect saliva specimens. And with a sensitive detection technology, we should be able to get good data out of less than optimal specimen types. So that's pretty much what I wanted to say. I think there are lots of discussions about sort of where is point of care testing going in this country. Are we not going to be back to business as usual for point of care testing until we have a vaccine? These are all topics we're highly interested in.
Yeah. Great set of comments, Dave. I'm going to turn to Matt now, and Matt, Roche is a very large diagnostic company doing a lot of work in this space, and I wonder if you could provide your perspective on how we move forward. And I really want to keep picking up on the themes that Dave and others have raised about not just being an issue of more tests, but getting tests into more convenient settings, and recognizing that those settings probably aren't going to be pharmacies and usual points of care, because COVID-19 is so much more contagious and severe than, say, a typical flu or strep throat or other things that can be done in those settings. But hopefully an alternative to pop-ups with extensive requirements for personal protective equipment. And as well, this idea of getting a capacity to share the data from these tests much more quickly and systematically to support a well-designed and effective surveillance system. So, Matt, over to you.
Well, those are excellent topics, and I think this is the right discussion to be having. As you know, Roche is a diagnostics company with infrastructure and technology that spans the different modalities from serology, point of care, molecular, central lab, and so all of these are very valuable questions to be discussing. I mean, I think David had some good comments specifically around the idea of collecting samples in rather than the standard point of care, to be collecting them in a mobile testing center where you have less risk for exposure for healthcare workers, which has become a major trend throughout this epidemic. The idea of self-collection, non-supervised health collection, this is also a very good topic for discussion, particularly because there's the air swab, as he elucidated, but I think then there's also the question of the specimen and the chain of custody as it travels back to a laboratory where it's tested, where there has to be a good chain of custody to ensure that the testing is adequate in order to get a proper result. I think those are really critical questions. Michael's comment specifically around serology versus nucleic acid testing. In the acute phase, it's clear that nucleic acid testing is the best way to do an initial diagnosis. But again, as somebody also with elderly parents, the idea of understanding who has antibody and what that means for people being able to return to work and get the economy back to where we want it to be, I think is really a critical question that needs to be addressed. So I'm really glad to hear that there, and of course the collaboration that we've had with the FDA has been fantastic, and that the dialogue is moving forward on serology-based assays as well. So the other thing, of course, is beyond just the PCR for the initial diagnosis, the idea of looking at antigen-based testing as well is a compelling option for potential decentralization of testing that I know a lot of companies are evaluating. But from my perspective, you have with this particular pathogen, a virus that has R naughts in excess of 3 in a lot of patients, and that kind of level of contagion is I think, as David pointed out, challenge some of the paradigm around point of care testing, in particular around some of the guidance you've seen from the different agencies around keeping healthy people out of hospitals when they're going to be tested because of the risk, obviously, for infecting other patients as well as healthcare providers, and the potential implications that has for being able to control the epidemic, and also being able to overload the healthcare system. So these are, I think, the real key topics, and I think it's important to get the perspectives from around the panel in terms of where they see this going. Personally speaking, or for speaking from the perspective of our organization, we're looking across the different modalities and evaluating them. But it's very interesting to see how those will be played out in terms of clinical implementation and how they're going to be used to shape healthcare.
Yeah. So we've talked about great comments, Matt, and we've talked about some challenges to the paradigm, both in the need for more effective diagnostic testing to be developed, and in the fact that we want to make it convenient, really accessible, still reliable, but typical point of care is probably not going to work in the foreseeable future. Mike brought up the issue of payment. So the usual way that these lab tests are paid for, there's a CMS or insurer claim amount. CMS has set it for the standard COVID-19 test and for the basic blood serology test. How do you all, maybe start with Dave or Matt, how do you all see these new kinds of tests fitting into the current payment paradigm where this is happening in a different setting and we're asking something more in association with the test, making sure it's done reliably in these alternative settings, and making sure the data from these tests, the results, gets integrated into an effective surveillance and response capacity?
Sure. So I'll maybe take part of it. I think, the question of how this would be paid for, I mean, it depends on who's responsible for the billing and who's responsible for paying for it in the first instance. I think it's going to require a bit of innovation in terms of the different models, in terms of how that's going to be moved forward. I mean, you see that with some of the at-home genetic testing, where it's just paid out of pocket. And I think here, where it's a public health question, it's a very different modality. So, yeah, I think if the patient collects it at home and then that is sent to a central laboratory, I think there has to be a dialogue around how the billing would take place for that. In respect to the IT piece, I fully agree. Obviously, there's clear requirements around patient data privacy, and that has to be reconciled with how reporting of the disease is handled if we're going to be able to manage effectively around how we monitor and track the outbreaks as they move forward into the future.
Matt, I'm sorry, Dave, any comments to add to that?
No, I think that was well said. I think that the potential for fixed laboratory testing and also mobile lab testing. We've talked with the Seattle Flu Project about deploying 16 module systems on a van to be able to test nursing home patients on site and generate maybe 50 results or 100 results over a 3 to 6 hour period. That's something that will need to have data connection as well. And how do you build that into reimbursement? That kind of, we're not used to that, right? We're not used to just doing spot checks from a standpoint of logistics and reimbursement. So the connectivity is important in that setting as well. And how do we get ultimately the data into where it needs to be for monitoring, and how do we get the data into the record for reimbursement?
All right, I'd like to go to Lauren now. Lauren, we had a chance to speak earlier in this on-the-fly adjustments to our webinar, but I'd like you to pick up on the themes from this panel based on your extensive policy experience at FDA and in government. So we've talked about several challenges where policy responses may be needed, both including facilitating the development of tests and the use of tests in these alternative settings safely. We've talked about building out a surveillance system with actual timely data sharing. We've talked about payments to support that, both to the labs and to the providers that might be involved. Pharmacies, for example, that set up special access maybe outside of their stores or other community-based settings as well as home. Your thoughts about important issues to think about going forward as we try to get to a really effective and proactive surveillance system here?
Sure. Well, I'll pick up on two of the points. The first one is, and we're all sitting here talking about surge capacity and additional tools so that we can really get to, essentially a positive negative world, like who has it and who doesn't, or who has had it and who hasn't. And we really need to think about the next order of testing and data collection, really. If you look at how cases are reported now on the CDC form, it's symptoms that the patient is experiencing and reporting and submitted. A lot of times that's done, and compiled in Excel spreadsheets. The testing centers that are collecting the information now don't have the normal working capacity to be filling this out and collecting the data in real time. So focusing on having the data infrastructure to support a better understanding of the disease, eventually getting to, risk stratification, understanding, who might be more at risk for hospitalization, starting to build that data set is where we also need to be going. I recognize the whole, positive negative is our biggest challenge now, but we shouldn't lose sight of our longer term testing and data infrastructure needs in order to have a much more effective healthcare system for treating this going forward. And then I think, the reimbursement challenges we already have with, who's paying for a test that a patient needs, who's paying for surveillance that, you can't say anyone needs, but we need as a public health system. I think we also need to build into the model that gets us, through the summer and the fall and recognizes that this virus is going to be around. So we need to think differently about the public health system that's going to support our care for patients and managing their needs.
Yeah, maybe I can go back to Mike on this one, since you made a strong point about the need for new kinds of payment, the need for a shift towards a focus on results being posted, on outcomes of surveillance, not just doing the tests. If one thing's clear on the payment side in the short term, in the response to the COVID-19 crisis, it is that fee-for-service payment is kind of out the door. Hospitals and other healthcare providers are just not getting the fee-for-service reimbursement that they were before. They need help and dealing with surge capacity, and they're going to get some additional assistance that's more at the facility or the population level. Mike, do you see some opportunities to build in as we think about further congressional responses and further steps that CMS and payers can take moving to this kind of more results and not just fee-for-service based system here?
Mark, I do. I mean, listen, when we have such complex issues, I think sometimes we just have to really simplify them to get at their core. We just, our government just signed a $2 trillion stimulus package. I don't think any of us believe that's the only one that's going to be signed over the coming months. So whether it's one of two or one of three or one of four, those are all reasonable debates. This is an administration that has thrown out the rule book to some extent in terms of how things get done. And some view that as positive, some view that as negative. But I think it is a fact that we're working with an administration right now that is willing to think differently. And so if we move forward with that assumption and recognize that we have 330 million Americans, if let's say it costs $100 worth of costs in order to get everyone tested. I think that's $33 billion. Let's say everyone has to have 2 or 3 tests. It's still south of $100 billion on top of what might be $5 to $10 trillion of investment, governmental investment in order to get this going. We can't pay for this, figure out how to pay for these tests, one payer or one health plan at a time. But perhaps we use this time as an opportunity to throw folks in a room, wherever we choose to do it, or on video, where we have the government's involvement, we have a decision maker from the private payers, from Medicare, and we actually work through a national solution here. Because ignoring it and just saying we're going to figure this out on a one-off basis is just going to leave us mired in what kind of where we've been for the last 50 years, or especially the last 20 years with diagnostic testing. But I can't help but think that there could be a forum, that there could be a way to, first of all, acknowledge these tests are not very expensive to run. These tests are extraordinarily valuable, especially if we link them through, we link that information to a national database. We put that in the context of trillions of dollars that we are going to spend as a nation right now, and I think necessarily so to help folks that are really going to be in dire need over the coming months, and then help us ultimately get out and get us back on track. And we think about $100 billion investment that brings private payers and Medicare together in order to figure out how to fund this at the national level. Seems like that would be a reasonably, it's not a solution, but it's too complex to say this is how you do it. But it seems like that's like something like that. To me, that's what has to happen as a step here if we're really going to work through this. You can tell me I'm super naive, and I know I am when it comes to policy, Mark. But I figure I have to, I don't know how else to do it.
Well, the best policies are the ones that support, that start with the goals in mind and then figure out how to get there. And I have to say, I haven't seen anything in my career, any situation in my career where people are more willing to step up and just do what it takes and figure out a way to support and sustain that. So, maybe a silver lining with this crisis is that we have a chance, perhaps with congressional leadership, administration leadership, and the private sector all coming together, states, local governments, I want to emphasize their role too, as Betsy did, to get this right. Just as an initial reaction, maybe I could turn to Matt and Dave for your thoughts on the path forward with respect to new approaches to payment and really getting this surveillance capacity done in the coming months.
Dave?
Sure. Yeah, I can comment. We're aggressively pursuing a ramp up in connectivity for all of our systems with C360. We do need some cover from HHS and possibly American Hospital Association to provide assurances to hospital and system CEOs that their data is secure, that it's HIPAA compliant, and that all the regulatory requirements are satisfied. We hope to be able to roll that out quickly. The laboratory information system connectivity is a separate story. We're going to get data from C360. We're getting it now. We're getting it from testing sites in New York and New Orleans. We can see it. I can see it this morning from the sites that are doing testing. But to be able to share that data with CDC, we need to have the right level of assurances that that's okay, and the sites have agreed to allow us to share it. I think that will all happen quickly. But in terms of even worldwide surveillance, I think that's something that we need to be ready to do as well, because we do have a lot of systems out there that can be used as sentinel systems for local outbreaks. We can maybe predict transmission pressure better than we can now in real time, and know where the hotspots are in real time, that capability we just didn't have before.
And Matt?
Sure. I mean, I think those are great points. I think, another angle is one that was brought up earlier, which is around government stockpile of tests to be able to flex to these outbreaks. I think one of the things you've heard almost all the diagnostics company manufacturers mention on this call is the ability to scale up their resources. And, designing a supply chain, nobody builds it with a couple 100% idle capacity. So how do you scale up in order to meet the epidemic in an appropriate way? And I think part of that, having spent a number of my years of my career on the pharma side of our business, having government stockpiles for diagnostics seems like a rational opportunity to be able to respond quickly when this spikes, because I think then that allows for the kind of preparedness that would make it more manageable.
Yeah, and not only the tests, but the reagents, the supporting materials.
Of course.
Right. Yeah,
that's right.
Yeah. I think there's additional interest in, and there will be after this, is somewhat resolved, a new interest in developing broad range detection capability that we didn't have before. So for instance, a broad range pandemic influenza detection capability that can be stockpiled, broad range coronavirus detection capability. How much better would it have been if we'd had stockpiles we could reach into that could detect any possible coronavirus that might emerge in the future because of broad range detection capabilities. These are all possible to do and possible to plan for. And I hope that we can see some investment in the infrastructure requirements for that to happen on the diagnostic side.
Well, we're certainly going to see a lot of investment based on congressional action so far, and as Mike mentioned, and I agree, more that's coming. The question is, Dave, whether it's done in a way that really builds this effective national surveillance system, that we're not going back to business as usual, either for surveillance on further risk from this epidemic, future waves, or from the future pandemic risk that undoubtedly will come. Lauren, let me go to you to see any final thoughts before we wrap up this panel, and I might try to squeeze in one or two additional comments from our audience. I want to thank everybody who sent in via the hashtag questions, comments to add. I've tried to work in a lot of those. Lauren, over to you.
Yeah, I mean, I think in addition to thinking about the stockpile, I think as we look at, these additional capabilities coming on, we can't look at it as like we just approved a test. We also have to look at it as we have now committed to a testing capacity. And we talked a little bit about that in the paper, Mark, and we haven't talked about it that much right here, that like the minute we know something's going online, we need to plan for what we think is the appropriate future use of that, where we want to see it, how we want it deployed, and what supplies we need in the background in order to keep that happening. And that I do think takes other parts of government, the logistics and the support to look at, okay, if we want this going out to 500 labs because it will increase our capacity by X amount, how are we going to plan for that to happen over the next 3 to 4 months if it's needed, and bringing in other parts of government to look at it as, approving a test and committing to a testing capacity to support it.
Right, and the payments line with it. And Lauren is referring to, there's several papers we referred to today. This is a paper on accelerating diagnostic capacity. It's on the Duke Margolis website that I talked about earlier. Quick question before we wrap up from audience. One of our participants has a spouse who works in, I think, in nursing, and has to go as part of that job, sees patients in different settings. Is she going to have to be tested regularly? And any recommendations about that for a hospital or healthcare workers who may go to multiple settings? That's open to anybody.
Yeah, I have. For me, this is personal as well. We've got a daughter who in Portland who is going to be assigned to the COVID unit in Portland as a nurse practitioner. A son who's in the operating room in Portland, and I think we need to provide options for our frontline workers. Some of them are quarantined, probably not positive, but it'd be nice to get them back into the workforce. We just need better tools for allowing them to get re-engaged or out of circulation. And the combination of being able to test them quickly and test levels of immunity and maybe qualify them for prophylactic therapy would be a great combination to be able to employ more efficiently than we are now.
Important element of this response. And then very quickly, viral load testing has become a very important part of HIV monitoring, of Hep C, chronic viral conditions. Do people see a role for innovation and testing in that area in COVID-19 as well? Again, open to anybody.
Yeah, this is not a classically quantitative specimen because of the variability in efficiency of sample collection. But I would say there are 1,000 ways to get a bad specimen. There's only one way to get a good specimen. So when you see a really high viral load in a sample, there's probably something going on there. And I think the ability to identify the supershedders in our midst is going to become increasingly important by virtue of looking at those values and stratifying risk of transmission, possibly risk of developing complications in inpatients based on those values. Maybe not strictly across a quantitative scale, but maybe according to quadrants of positivity.
Great. Thanks very much for those comments. I want to thank the whole panel, not only for being part of such a great discussion now about where we are, and even more importantly, where we should be headed and how to get there, but also for all that you all are doing right now in the pandemic response and to help us succeed in against COVID-19. I want to thank everyone else who's participated as well in the event. Special thanks to actually Nicole Lurie, who tried hard, but we just had connectivity problems. As you heard, one key part of further response here is an area where she's an expert, and that is aligning the federal government's role in aligning the needs out there for countermeasure materials, including diagnostics, and the additional supplies that would be needed in the stockpile, as we've talked about today, with the demand for these supplies around the country country and in the event of future surge needs or outbreaks. So thanks to all of you. Let me go to Lynn Zadowski as we close out this session. Lynn from the Alexandria Summit, thanks for working with us on this.
Thank you so much, Mark, and thanks to our partners, the Duke Margolis Center for Health Policy. A very special thank you to Mark McClellan and Marianne Hamilton Lopez for their leadership on this topic. We're honored to partner with you on today's important discussions. I'd like to thank the Alexandria Summit team and my Alexandria Summit co-founder, Joel Marcus, Executive Chairman and founder of Alexandria Real Estate Equities, and join Mark in thanking all of today's panelists. And to everyone who joined us virtually, we're truly honored to be part of a community that is collectively driving toward a solution to the COVID-19 pandemic. Today, we came together in the midst of one of the most profound threats to public health in over a century. And with this community of stakeholders gathered here, we have an urgent call to action. As we discussed today, efficient, reliable, widely deployed diagnostic tests are critical to our immediate and ongoing response to the COVID-19 pandemic. Robust systems are needed to detect when and where the virus is spreading. Diagnostic capacity will provide the foundation to turn COVID-19 into a more manageable threat in advance of having safe and effective vaccines and therapies. And as we've talked about today, there is perhaps the need for a national solution. This will enable the significant and sustained reduction in the social distancing and the physical isolation measures being implemented now, and will help mitigate the associated impact on the overall well-being of Americans and on the economic health of a nation. It's critical now that we manage and we leverage our powerful collective voice to drive how we can navigate this crisis and how we as a nation adapt so we may ultimately return to the new normal. You know, together we'll get through this, together we'll find a solution. I just want to say to everybody on behalf of Alexandria, be safe, be well, and we look forward to continued discussions. Thank you.
Yeah, my thanks too, and I'd like to add my special thanks to the team at Duke Margolis. Like everybody else in this country, we've had to go in a matter of just a couple of weeks, completely virtual, and still help stand up, do our part in standing up this response. Looking over the list of participants today, thanks so many of you for joining. You're in all sectors of this response: public, private, state, local, different parts of industry and the community. This kind of working together is what it's going to take. This will not be our last event related to COVID-19 policy responses. We hope you'll stay in touch with us. More papers coming, more events coming. We hope to see you soon and look forward to a lot of progress as we get through what's going to be a very tough month of April. And I hope people came away from this knowing we do have some very big challenges, but with the right steps, we can move forward towards reopening and towards a lot more progress both here in the country and around the world. Thank you all for joining us today.